Welcome to Building Your Defense, brought to you by Brownlee LLP in partnership with Invista Forensics, Viewpoint, and Westbridge. Sitting beside me is Manpreet Kaur.
Hi.
My name is Blazak. We're both lawyers with Brownlee LLP, and joining us today remotely is the esteemed Dr. Curtis Hlushak. Welcome.
Good afternoon. Thanks for the invitation today.
So I just, before we get started in our interview with you, Dr. Hlushak, I'm hoping to provide some background comments. So this series is about emphasizing the importance of not just arguing the holes in the plaintiff's claims, but how, by hiring the right experts, we can build your defense. So to that end, we're inviting leading experts in their respective fields to share their experience with us. And any questions that you have in the chat, we'll put them into the chat and we'll answer them. So I just want to give you a reminder on the role of experts in litigation, just to have that million-mile overview. So two main kinds of experts. There's investigating or consulting experts. These are going to help litigants understand what actually happened, help build up a theory of the case. These reports are often privileged. Then there's independent opinion experts, and that's the role Dr. Hlushak often plays. So this is just opinions. Your next door neighbor Joe has an opinion, and so you might be asking what you need an expert for. And so, as a general rule, a witness at trial can only testify to facts within their personal knowledge and experience. So your neighbor Joe can observe the plaintiff holding the back of their neck, wincing, complaining of ongoing pain following a car accident 3 years ago. Joe is not going to be able to opine that the car accident did or did not cause a whiplash-style injury. By contrast, Dr. Hlushak can be qualified to render such an opinion. So experts, as a consequence, are extremely valuable in litigation, but they also can issue some commensurate bills. So it's important we understand how how to efficiently utilize their assistance. So with that, maybe we can turn to you, Dr. Hlushak. And so as a highly experienced specialist in physical medicine rehabilitation, you bring extensive expertise in treating and assessing whiplash and musculoskeletal injuries. You're, I understand, fully certified to conduct independent medical examinations, and I also understand that you have significant decades of experience serving both plaintiff and defendants in personal injury cases. So we welcome you to the podcast, and I hope you could tell us a little bit more about your background, what led you into physiatry, and maybe you could explain for us in your own words what that is.
Well, sure. Thanks again for the invitation to be here. So my academic training in terms of undergraduate includes a partial arts degree from the University of Alberta. I transitioned to a kinesiology program at the University of Calgary, in fact, and completed a degree there. After that, I worked for Millard Health, which is the WCB Rehabilitation Center in Edmonton, for a few years. And during my work there was really when I became engaged in medicine and decided to go back to medical school. So upon completing medical school, I completed a 5-year residency program at the University of Alberta in physical medicine and rehabilitation, or physiatry. During that, I also completed a master's degree in rehabilitation science and then entered practice. I've been in practice since 2012. My practice includes exclusive outpatient musculoskeletal medicine, so treating patients on a day-to-day basis with things like chronic neck and back pain, arthritis, bone and joint conditions, and sport medicine. Also hold a diploma in sport medicine. I've been certified as an independent medical examiner through the American Board of Independent Medical Examiners for several years now, and have probably conducted upwards of 800 to 1,000 IMEs over the last 12 to 15 years. I also am a clinical lecturer with the University of Alberta, so I do a little bit of bedside teaching for medical students and residents. So that's kind of my history and day-to-day practice.
Well, that is indeed an impressive resume. So I just want to give you some signposts just to help you and maybe the listeners understand where we're going with our questions today.
Yeah.
So the first thing I'm going to ask you about is the retention process. How do we hire you? What steps need to be taken? And then from there, I'm hoping you'll actually take us behind the scenes to give us and the viewers a little bit of a sense of the process you follow in the build up to preparing an independent medical examination report. And so then we're obviously kind of defense focused. I understand you do work for both plaintiffs and defendants, but we're very interested in developing expertise in the principles and evaluating the claims being put forward by plaintiffs. And so then finally, we'll close off our session by exploring some of the practical steps that lawyers, adjusters, and so forth can follow to ensure that your reports are the highest quality. And we'll be answering any questions. Please feel free to put any questions that you might have into the chat. So, with respect to retention, could you talk us through your experience about how you're retained to perform an IME and what kind of information you need from the outset, just at a high level?
Sure. I mean, the simplest way is for a referral source to issue a request through a company like Viewpoint. They will then contact me directly with a letter of instruction. Um, I'll confirm that there's no conflict of interest with the examinee, and then a date and time will be scheduled, usually no sooner than about 2 to 4 weeks in advance, sometimes 2 to 4 months in advance. That just gives a little bit of lead time to then send me the medical documents to review in advance of the case.
Excellent. So, just as a couple of other points there, in terms of the information that you need, presumably you need some information about the accident, injuries, but also maybe there's specific questions that are helpful to guide your inquiries.
Yeah, so obviously, I mean, I need some demographic information about the individual to confirm that there is no conflict of interest. The type of accident, slip and fall versus motor vehicle accident versus another type of injury. That helps me determine whether or not I'm actually the most appropriate specialist to see that individual. Those would be the key parts of the demographic basic information, and then the letter of instruction, which usually outlines specific questions. Now, typically, I'm asked to answer the same types of questions. Describe the injury, describe the treatment that was provided. What are the functional implications of the injury? What are the current symptoms? What are the objective and subjective findings? What are the diagnoses? And then any additional treatment recommendations that I have. And then, of course, causation is usually asked as part of that. Now, some questions can be more specific, and I would encourage anyone sending a referral to be as specific as possible with the questions they would like answered. That helps me provide detailed and specific information. And if there are specific terms that you're wanting to have comment on, for example, does this individual have a substantial inability to perform X, Y, and Z? It's also useful to provide what your definition of terms like substantial disability are, because those do change between jurisdictions.
Mm, that's useful to know.
Right. And so thank you for providing that information about the retention process and just taking some of those initial few steps, such as conflict checks, the importance of having very, very clear questions so that you can then provide clear reports and address those questions. So all of that is done. What's next? What is the actual process of conducting an independent medical examination from start to finish? Can you walk us through that process, including things like physical examination, clinical interviews, reviewing documents, things like that?
Yeah, absolutely. So, ideally, the first step is for me to go through the medical documents in advance of seeing the examinee. Now, that is dependent upon how soon I get those in advance of the assessment, but most of the time it's not an issue. Some of the documents can be quite voluminous, up to 3,000 or more pages. But I do spend some time going through those documents in detail before the actual assessment of examining the individual. On the day of the assessment, which would be the next phase, is the examinee will come into the appointment usually about 30 minutes before I see them to complete an intake form that I have prepared. It's 7 pages in length, but depending on the individual's experience doing these, maybe their education level, language issues, it can take up to 30 minutes or more to complete. But it does provide me with information in their own words about the questions that I am then going to ask them in detail. So it gives us a bit of a starting point to understand their perspective. I will go through that as part of the history taking with them in detail afterwards. and I'll ask any additional questions that might be required for clarity. That takes probably 15 to 20 minutes, and then I'll spend the next 15 to 20 minutes taking a more detailed history about their present symptoms that are, stemming from the accident or injury. Once that's done, I do a detailed physical examination, which usually includes and almost always a full neurologic examination and then a musculoskeletal examination of the body parts affected. Sometimes we'll do some additional functional testing, and by that I mean, looking at how they move around, their gait assessment. We'll do some simple bending, lifting, twisting. That's not as common. I usually reserve that for an occupational therapist, for example, through a functional capacity evaluation. But I do try to get an idea of, some simple day-to-day activities that they can demonstrate in the office. Once that's done, I'll usually ask them to complete some questionnaires, and the questionnaires are more functional inventories about, describing their pain in more detail, their functional limitations. These are standardized questionnaires that are used across the board and very well validated. And I'll select those based on the indication, based on what I hear from the individual during the assessment. I'd rather do that than bombard them with 5 or 6 questionnaires that 4 or 5 of them may not be necessary. So once that's done, usually the examination with the individual is complete. Most of the time I can get through that in about an hour, but depending on things like language barrier, if a translator is required, the number of body parts that are affected, how much people want to talk. These assessments can extend 90 minutes and very rarely beyond that.
Mm-hmm.
Once I'm done that, sorry, were you going to say something?
No, just go on. Continue,
Okay.
please.
Well, once I'm done that, I'll usually dictate at least a draft report of the history and physical examination findings immediately afterwards. And then over the course of the next few days, I'll prepare the report referencing the medical documents just to do any consistency checks or anything that's come up in the assessment that I want to recheck from the medical documents. Then the report is prepared, it's sent to the referral source after a quality assurance review is done. And that's basically it.
Great. You mentioned reviewing medical documents, and so just curious to know how much weight would you usually give to reviewing these medical documents, particularly documents preceding the 3 to 5 years period from before the date of loss? How much weight would you give to review of these documents vis-a-vis the physical examination component of conducting an IME?
Well, I think the medical document review is extremely important and extending as far back as required. Just by way of example, I had a recent case a few weeks ago where the injury was in 2020, so 6 years ago. The symptoms that the individual was reporting, neck and back pain, actually extended back in the medical documents to 2014. So, and there was well-established documentation of this every year for several months each year leading up to the accident. So that really does have an impact on comments with respect to causation. So I do rely on them heavily. Now, some of the documents are more important, I think, than others. For example, if there's an emergency department record, that can be quite useful because that usually gives you the immediate symptoms and physical examination findings that are fresh in the examinee's mind and as well as the physician seeing them. The AB forms that the physiotherapists or chiropractors fill out can be quite useful because that does summarize the rehabilitation treatment. If there are family doctor notes that are relevant, I mean, some individuals have seen their family doctor regularly for decades for coughs and colds. That's not overly relevant to me, but it's hard to know until you do go through these to find out if there is pre-existing conditions that could be contributing. So I do think it's valuable in that regard. And then also afterwards to confirm what the individual is telling me about the treatment that they've been provided and does that correspond with what the documents indicate. Now, there are some chart notes that are often just copy and paste from one session to another that don't really offer much value, but those are easily identified. And I guess for my sense, I can just simply go to the most recent chart note because it's usually the same all throughout. So bottom line, medical document review is a key component. Now, how does that compare to the physical examination when I see them? Well, it's important, but physical examinations can change over time. How they presented a few years earlier can be different than how they present today, but there are general consistencies that we look for to make sure that there is, corroborating evidence for their claims.
Sounds good. Sounds like you have a process in place where you will um, assign weight to these medical documents and then compare and contrast these documents with how an individual is presenting. And this also reminds me of one of my experiences on a file where we had this plaintiff and previous records from their family doctor indicated that they were actually recommended surgical intervention for some debilitating knee issues prior to the accident. And so it was very clear that in any scenario, in any situation, they would have gone ahead and gotten that surgery whether or not the accident, I mean, of course, the accident exacerbated some of these symptoms, but we were very clearly able to identify that this was a pre-existing issue. The surgical intervention was not primarily because of the accident, and that really helped us, and that provided us key information and helped us reduce our exposure. So, yes, I mean, I agree that these documents provide key insights, especially sometimes the discharge notes where uh, the physiotherapy treatment charts, for example, will say they have attained maximum improvement and they're good to go and there's a full recovery. They can go back to work, or in fact, they have returned to work. And then we notice that sometimes when they go back to the independent medical examiner, they will report ongoing issues, concerns, recurring issues. And so I think the previous medical charts help us identify some of those inconsistencies as well. Have you experienced anything like that?
Yes, I have. And I would like to also add that if there is diagnostic imaging reports pre and post accident on the same body part, that can be quite useful. For example, I do recall an individual who had admitted and there was documentation of pre-existing back pain and was claiming that a disc herniation was as the result of an accident. However, there was a pre-existing MRI prior to the accident in question that did demonstrate a disc herniation that was consistent with his clinical examination at the time. So in diagnostic imaging in particular can be very useful pre and post.
Actually, just to kind of jump in that, the question I have, there's the diagnostic imaging. There's pictures stored somewhere, but for the most part, the affidavit of records that I'm getting, you know, the reports providing the various impressions of the technicians, and um, to what extent do you think it would offer value to just try to be fighting for like the underlying pictures, the X-rays, the MRIs themselves, and would you review them, or is that within your expertise?
So that's an excellent question. Just to be clear, the diagnostic imaging reports are actually reported on by a radiologist, so a physician trained to do that, not so much a technician. Um, when it comes to reviewing the images, I mean, I do review images in my day-to-day clinical practice, but for the purposes of an IME in a medical legal case, I think it would be important that if images were reviewed, that those be done by an independent radiologist to make sure you're getting an expert opinion on interpretation of those images, which I am not trained to do.
Great. And so once that process is completed, once you've done the physical examination, document review from start to finish, what are the types of reports that you could produce following an independent medical examination, and how those reports are used in litigation, you think? And obviously, we can also comment on how they can be used in litigation, and that's something that we can address. But particularly interested in what type of reports do you produce once the medical examination is completed?
Well, that's dependent upon the nature of the question and the referral source request. I mean, the vast majority of the reports I prepare are medical legal, independent medical examination reports from a physiatry scope of practice. So they would include sections on, as I mentioned earlier, treatment summary, functional impact, current status, other medical history that may or may not be relevant, physical examination findings, review of the diagnostic imaging if available, comments on diagnosis and causation, results of any of those questionnaires or functional inventories, usually a section on prognosis and whether or not maximum medical improvement has been reached. I will often provide treatment recommendations and then a summary section with an appendix of the relevant information from the medical document review. I'm not sure if that answered your question, but I mean that the types of reports can either be a medical legal report, a disability assessment report. Sometimes I'm simply asked just to review charts and not actually see the individual and just provide a summary of what I've found in the medical charts based on the questions asked.
Okay, perfect. And then you also mentions that you would also look at some of the functional limitations while assessing these plaintiffs. So how do you do that? How do you assess someone's functional limitations in terms of a person's ability, especially to return to work, or just return to normal activities of daily living?
If I could jump in on that question too, if you could, I'm also interested. The AMA guides, we often get
Yeah.
like 1% impairment, 12% impairment, and
Yeah, that's always a pain point. It's
Yeah.
like how is this person, how do you assess the impairment rating? What is the basis of it? And I think we're particularly interested also in knowing how these functional limitations will impact an individual's return to work. Because a lot of times we're assessing these damages, and the huge chunk of damages is their loss of income and loss of earning capacity. So from that perspective, how are you able to objectively comment on someone's functional limitations?
Sure, I'll try to answer that question in two parts, one about the functional assessment and then second about impairment ratings, if that's okay.
Sure.
So, just to be clear, although I didn't reference that I do some type of a functional assessment, it's very cursory and bedside. It's not a formal functional capacity evaluation. And if there is a question about suitability to return to work, I would often recommend that that be obtained through an occupational therapist or physical therapist. However, in the examination room, you can get an idea of someone's sitting and standing tolerance, walking tolerance as well. You can get an idea of how they move around the examination room from the chair to the bed and getting on and off the bed, how they take on and off their jacket and other clothing if needed. Can they bend over and tie their shoes, put them back on without any, overt pain behavior, those types of things. So see, these are all kind of simple internal consistency checks that I would look at during an assessment. For example, I do recall a case where someone was mentioning that they weren't able to lift their arm basically above waist level, yet when I asked them to, take their jacket off, they were easily able to take their coat off and hang it up on the hook of the door. So clearly, when we moved on to the range of motion assessment and they were lifting their arms like this, that was incompatible with what they had previously demonstrated, right? So that's kind of where my functional assessment would be limited to. When it comes to making comments about return to work, I mean, I do take a detailed occupational history. So what job were they working at? How many hours? What are their typical duties? And then knowing what I see on the physical examination, and for most part, unless it's an obscure type of occupation, I have a good idea of the physical demands of that job. I can safely and confidently make some suggestions about return to work. I think it would be extremely rare where I would say someone is completely incapacitated from work. I think most people could do some type of work in a sedentary position. It may not be their pre-accident occupation or capacity, but I do encourage a return to work because the longer an individual has been off work, the less likely they are to return, and that's probably the biggest predictor of return to work. Does that answer those functional and return to work questions? And would you like me to talk about the impairments now?
Yeah, I think so. Sure.
Yeah. So impairment rating, we could probably have an entire webinar just on that.
Mhm.
I'm trained to use the American Medical Association Guides 6th edition, which has really de-emphasized subjective reports and focuses the impairment ratings on objective findings. So the way an impairment rating is done, and it's a little bit difficult to verbalize this without looking at the charts and tables, but the most important step in that is to make a diagnosis. Once a diagnosis is made, you actually go to the guides. It's a thick textbook. I don't have it with me here, but you identify the appropriate diagnosis within the guides, and then there's a series of tables that basically lists impairment ratings within a range of a percentage whole person. You identify which diagnosis and class an individual falls in, and then you modify the number within that range based on the results of those questionnaires that I spoke about earlier, objective physical examination findings, and diagnostic imaging findings. After you do that and you incorporate all the different diagnoses, you come up with what's called a combined whole person impairment rating. And that's basically entering numbers into a table and getting a percentage whole person impairment. So there is a bit of art and science to this as well. It's not perfect, but it is what it is, and we're kind of limited to the constraints of that. It's not I'm picking a number out of the air and saying, oh, I think this person's 4% disabled and this person's 8% impaired. That's not how it works. It's a very structured and systematic approach to doing it, but based on some math and first of all making the diagnosis. There is an alternative to impairment rating or sorry, a diagnosis-based impairment rating, and that is a pain-based impairment rating. However, the cap for that based on the AMA 6th edition is 3%, and it is exclusively based on the results of something called a pain disability questionnaire. So that is a 15-question questionnaire that an individual answers by circling answers from 1 to 10 for each of the 15 items. And it's a self-perceived indication of how pain affects various aspects of their life. That score is then totaled, and depending on the total score, whatever range that falls in, it can be from 0 to 3% whole person. You really only use that pain-based impairment rating if there's no applicable diagnosis-based impairment.
That's very, oh, sorry. Do you have a
Yeah.
question?
Yeah, just one
Okay.
quick question. And it's interesting to note that there's like these different types of assessments when you do your impairment ratings, and there's this pain-based uh, impairment rating process where there's no diagnosis. I'm just curious to know what happens when there's lack of treatments, or there's just gaps in treatments in terms of there's non-compliance and lack of mitigation, not following the recommended treatment procedures and protocols. Do you factor those things as well, factor those in your assessment, or make comments about that in your reports?
Yes, I do. I mean, I have a section called treatment summary, which is the reports of all the treatment provided to date. In the document review, I outline the treatments that are documented as being provided. And then I should actually step back and say you cannot make an impairment rating until an individual has reached something called maximum medical improvement, or MMI. MMI basically means that an individual has reached maximum improvement after undergoing all of the medical and surgical treatment available to them. So if someone hasn't had appropriate treatment, or if they've been non-compliant, or if there have been treatment gaps, it's probably not a situation where MMI has been reached. However, I think it's within individuals' rights that if they are offered a treatment and they decline that treatment for whatever reasons, that does have to be taken into consideration.
Very interesting.
We have a
Yeah.
great audience question. The question is this. You mentioned you use a specific chart. Are there different charts that have different, more liberal or conservative assessments?
Again, I'm only trained in the 6th edition. I believe the earlier editions may have weighted more heavily some of the subjective reports of individuals and factored into consideration things like range of motion of the spine, which we no longer use in the 6th edition guides. So the calculations are different, but in a general sense, I believe the 6th edition probably generates a lower impairment rating than previous conditions for essentially the same diagnosis.
But I think potentially another kind of tackling the same question from another angle. To what extent do you think that you have like your discretion influences the overall rating? So how objective ultimately is a 12% impairment rating? Would it vary across experts? Would there be differences of opinion, reasonable differences of opinion, should we say?
Yeah, again, excellent question. And I have seen significant discrepancies between different specialists and assessing physicians in providing an impairment rating for the same condition. The impairment rating is somewhat complicated, and I do think it requires additional formal training in the guides, which various individuals have. That's what that CIME designation that I referenced earlier from the American Board of Independent Medical Examiners provides. But as I said, it does heavily weigh the objective findings, and those should be relatively similar between examining physicians. So for example, if we're measuring range of motion, which is an objective finding, you actually measure it with a goniometer, which is basically a tool to measure angles of range of motion. For example, in a shoulder, wrist, knee, whatever. When we're talking about other objective findings from a neurologic perspective, that's the presence of weakness and what the grade of weakness might be. Is there actual atrophy of a limb? So you actually measure that with a tape measure. So these are hard to subjectively interpret if you're doing them correctly.
Well, that's very reassuring to know that this is more of an objective process, and that, especially as you mentioned, that the sixth edition you said brings the subjectivity down, and it's a little bit more objective. So I think it's quite reassuring to know that these are more objective in nature and can address these questions and reduce the biases and predispositions and discretionary approaches as well.
Yeah,
And
I might just add too regarding the subjective component that I referenced some of the functional inventories, which are individuals' responses to questions, and there actually is a check within the calculation of an impairment rating that if the results from that modifier are significantly different, and I won't go into the math, but there's numbers that are used. If they are significantly different from the objective findings in the diagnostic imaging investigations, that using that component to calculate the impairment is actually excluded. So then it would become exclusively objective physical examination findings and diagnostic imaging.
Well, it sounds like it would be really important then for us if we get there's a plaintiff side physiatrist who performs this kind of assessment, that we get the underlying documentation and tests that they're using, because it seems like there would be some similar analyses, and you could help us critique that or evaluate what it is that they're saying. I was going to move on to
Yeah.
Okay.
Sure.
So AI, it's all the rage. Everyone's talking about it. People, the different industries are using various programs. Of course, there's a lot of concerns about AI, I guess, both in terms of confidentiality, but also I think I like a lot of these, that kind of comes down to the company level, what the softwares you're using. But the big thing is controlling for hallucinations. So there's concerns about AI use. In your practices as an expert, have you seen people starting to use AI softwares?
I have, and I actually use a couple of programs myself. These are not from a clinical perspective in the sense of making a diagnosis or treatment recommendations. Rather, they're meant to help with the process and logistics. So one of the tools I use is a document sorting tool. So for example, if I get several PDF documents on a case, I upload those to this AI software program. It will then sort through all of the documents, index them however I choose, whether that's chronological order by specialist. It will also exclude duplicates, which is very useful. I've referenced earlier in the talk that there were, well, in fact, 2 weeks ago, I had a 3,300 page file sent to me that once the duplicates were removed, reduced it to 1,900. So it saves me a lot of time and saves costs on your end. But it's also very useful because I can search by keyword. So for example, if somebody comes in with back pain and they deny a previous history of back pain, I can set date range limitations on it to look only at the pre-accident documents and just enter the keyword low back pain, and it'll find every single document that has that notation in it. I can also search by just looking at the diagnostic imaging results, specialist consultation letters, physio notes, whatever. So I find that extremely useful. The second tool I use is a scribe tool. So recently I've changed my practice a little bit, but of course, after obtaining consent from the examinee, what the scribe tool will do is basically listen to the assessment, and it will take the medical information out of our conversation and build my report in terms of things like past medical history, current medication use, etc. I would still read that report word for word and make any changes because there are still errors that are made. But recently, I haven't been doing that as much. But I do think personally, AI is here to stay, and we have to try to embrace it and find ways that we can leverage it to make our lives easier. And I would encourage lawyers, insurers, anyone who's handling these high volume medical documents to look at a documentation sorting tool AI tool because I do think they are very useful. And they're all vetted. I mean, I don't use anything that hasn't been approved by the College of Physicians and Surgeons for privacy and confidentiality.
Yeah, that's
Mhm.
that's going to be really important. I think that
Yeah.
that is important. Okay, so shifting gears here a little bit, I
Yeah.
want to talk about some common diagnoses that you might make, but just in terms of what I'm getting at in particular, I'm trying to give people a sense of what is your role, because there's, how would your opinion differ from an orthopedic surgeon, or earlier we were talking about functional capacity assessments, and so just when should we pull the Dr. Hlushak out of our toolkit, so to speak? So with that in mind, could you describe some of the common conditions you assess as a physiatrist, such as soft tissue injuries, chronic pain, concussions, and challenges associated with evaluating these conditions?
Well, just before I do that, I just might make the comment that physiatry sounds very specialized, and it is, but it's still a very broad specialty, and people work in various different areas of medicine within physiatry. So you can be a neurophysiatrist and work with stroke patients, brain injury patients, spinal cord injuries. You can be an amputee physiatrist dealing with obviously patients with amputations. There are other specialist physiatrists that work with cancer rehab and burns. And then there's the musculoskeletal physiatrist, which is essentially what I do. So to that end, I mean, as I mentioned at the beginning, my day-to-day practice involves seeing a wide spectrum of musculoskeletal conditions, from sprains and strains through to fractures and you know, disc herniations treated with surgery. So that's really the wheelhouse that I operate in. Of course, a lot of those conditions are or do result in chronic pain. Chronic pain is simply meaning that pain persisting more than 3 to 6 months beyond the expected duration of tissue healing. So invariably, given the wait times to see people like me, most people come in with chronic pain. Although I do some acute care sports medicine as well, in which case that wouldn't apply. As to when you might want to consider a physiatrist in your assessments, I would say there's probably two time points, and I'll just vaguely classify them as early and late. Early, you might want to get a physiatrist opinion basically to confirm the diagnosis, ensure that the examining your client is on the appropriate treatment plan, and identify if there's any risk factors for prolonged recovery. For example, if there is someone presenting with a concussion after a car accident, let's say, and they have a history of 4 previous concussions, even if they're sport related, if they have anxiety, depression, a history of migraines, these are all risk factors for persistent concussion symptoms and likely ongoing symptoms as a result of the concussion from the car accident. There are a host of conditions, degenerative changes in the spine, degenerative meniscus tears in the knee, rotator cuff tears in the shoulder that present themselves as we age in almost everybody at some point in time. So if there's a question as to whether or not the injury resulted in a specific diagnosis, that might also be a time to consider an opinion from someone like myself. And then also to ensure if there's any early referrals that should be made, for example, to a psychologist or to a surgical specialist to deal with surgical diagnoses. On the late end of the spectrum, and by that I mean, let's say we're 2 years post-injury, the individual you suspect is at MMI, you might want to ask someone like myself to see them to confirm, in fact, that someone is at MMI, they've reached maximum medical improvement, that their condition is permanent. You may or may not choose to request an impairment rating. I think that's usually done more by the plaintiff side than the defense side for obvious reasons. But an impairment rating at that time point would be appropriate. And then you also want to make sure that future treatments that are recommended are essential and necessary. And by that, an example would be, I recall one case where an individual had 110 physiotherapy treatments since the injury for a whiplash. And basically, they were coming in and having a hot pack and what we call modality-based treatment. So machines that were placed on them, and there was no active component to that, no exercise prescription. It was just come every twice a week for the next 2 years, and we'll continue to treat you. And I can think really of only one individual that was benefiting from that, and it wasn't the examinee. So
Mhm.
I think, from an ongoing treatment perspective, what would be the recommendations for acceptable and appropriate treatment?
Yeah, that's going to be really important in like our an assessment of special damages. Special damage claims can be huge. Future cost of care
Yeah.
claims can be huge, and we get functional capacity assessments. And in terms of the recommendations from the physiologist, they it's all the goodies. It's all the heat treatments and the TENS machines. It's you know automatic vacuums, etc. And so then trying to get a sense of what is actually necessary is extremely helpful. And so like be appealing to a physiatrist for that to render that opinion, because again, we were talking earlier, there's the fact witnesses, the description of like this is what treatments a person has had, and are we going to make the inference that because they had those treatments that they needed those treatments, that those were effective treatments and they need them going forward. uh, we need an expert to be able to help us out with that. This might be getting too much into.
Do we have a
We do
question?
have a quick question. Are you able to assist with burn injury cases?
No, that's completely outside my scope, unfortunately.
Okay. Yeah, so this might be a little bit too much into how the soup is made, but we talked about neurologic assessments, and and so kind of taking a step back, what do you mean by a neurologic assessment? Are you a neurologist? Or in terms of a concussion, a person has various issues with their nervous system. What do you mean by that?
Yeah, so no, I am not a neurologist. However, physiatry is very neurology based. As I mentioned earlier, the individuals work in stroke, brain injury, and spinal cord rehab. So we do have a heavy foundation in the neurological spectrum of medicine, probably spending the equivalent of about 2 years of our training on that end alone. So, we are more than capable of conducting a comprehensive neurologic examination, examining the nerves that supply the head and face, strength, sensation, reflexes, um, these types of components. And so, I think every physiatrist, once they've completed their training, would be more than comfortable in conducting that type of an assessment. But also, musculoskeletal conditions are often accompanied by neurologic injuries. So if you have a fracture around your shoulder, you can get a nerve injury, and you need to be able to assess for, coexisting injuries as part of the assessment.
That makes a lot of sense. So I think that was helpful. In terms of we've covered up some of the key areas of distinction in terms of that I wanted to cover. And now this is a hot topic question. Like I'm reviewing motor vehicle accident claims all the time, and then in more or less every single one, it's whiplash. And so I was wondering if you could give me kind of like an archetype of like what a typical pattern of recovery for a whiplash case that doesn't give rise to chronic pain. And I can imagine you're a little bit this is kind of a delicate question for you to answer, but I mean I think it would be very helpful for our listeners and ourselves to just to develop like some low level stereotypes for the purpose of honing uh, our sense of when are there irregularities such that we need a physiologist. That's really what I'm trying to get at with this. But yeah, are you able to provide some guidance on that?
Sure. I don't feel like it's a delicate thing to discuss. I mean, I will say though, however, that I don't see the individuals who recover from whiplash because by definition, they don't have the need to see a physiatrist either in my clinical practice or for an independent medical exam. So my view is biased towards those who have persistent symptoms. About 50% of individuals after a whiplash, meaning a spinal acceleration deceleration injury to the head and neck, will have persistent symptoms 6 to 12 months after the injury. So that's a significant amount of people if you think about it. These are usually soft tissue injuries affecting the musculature of the neck, the ligaments of the spine. They can sometimes involve the small joints of the neck called facet joints and produce chronic neck pain, sometimes with pain referred to the shoulder blade or arm region. So, if somebody is presenting with persistent symptoms more than 3 to 6 months, by definition, they have chronic pain and they have chronic symptoms from a whiplash if that was the cause.
Mhm.
In terms of like presentation of pain, someone has a well, let's say your expertise is more in chronic conditions. Uh, Someone has a chronic whiplash condition, they have some chronic pain. Should I be expecting in their treatment charts, today I've got 2 out of 10 pain, a month from now I've got 8 out of 10 pain, and then I go back down, or should there be some consistency in their subjective reported pain symptoms? Are we able to make kind of stereotypes like that?
Unfortunately, I don't think so. Every patient is different. Pain is a subjective experience that only the individual can truly perceive. We can't measure that with any tool or device in our clinic. But pain is also influenced by several factors. There's something called the biopsychosocial model of pain. So biological factors, so the mechanism of a whiplash injury, an acceleration, deceleration injury to the spine, and then all of the psychosocial components that contribute to an individual's makeup. And that can be, you know, uh, even things like pre-existing abuse in childhood, workplace distress, other injuries, interpersonal relationships, poor sleep, other medical conditions, obesity. Like this is a whole package that you have to consider. And I think it's difficult to attribute, someone's entire pain experience just to one motor vehicle accident. Yes, that might be a component to it, but it's more than that. If somebody is developed a chronic pain or chronic pain syndrome in particular, and by that I mean they become excessively dependent on family members or healthcare providers for treatment. They've withdrawn from their normal social milieu. They no longer go to work. They don't participate in their hobbies. They require excessive amounts of medication. They develop mood symptoms, depression, anxiety. Uh, Clearly, there are other factors, I think, that are usually contributing to that in most individuals.
Yeah, excellent. And
Just before,
yeah, sure.
we got some question about CE credits. So the email we've circulated, you should be able to respond to that. And if you provide us with your emails, we will be sure to get your issue our C certificates. And so if you do that today, I understand there's a deadline today. So if you get that to us right away, then we'll issue that. If you have any questions about where to send that email to, we can follow up with you at the end of the presentation. Sorry for interrupting.
Oh, no, no problem. Just because this was a very interesting kind of comment made by Dr. Hlushak about the fact that pain is subjective, it just kind of triggered my curiosity even more because we see this happen a lot of time. And I think the fact that pain is subjective indeed, and that there is a lot of self-reporting, makes it all the more challenging because, like, how do you identify? There's like so many red flags, and even just as you mentioned that there's so many other factors like obesity, childhood abuse, trauma, other stressors in an individual's life. Is there a way to sort of demarcate, that this is where the pain is coming from? This is specifically from the accident, or this was an aggravation as a result of the accident, and this is something that can be attributed to other factors such as lifestyle issues, psychosomatic symptoms, stuff like that. Because at the end of it, we're always looking for more of an objective commentary and conclusion on pain levels, on chronicity of someone's injuries, and it's very helpful to be able to identify some of these causes and issues and demarcate these factors.
Yeah, that's the million-dollar question. I mean, as you mentioned, it's subjective in nature, and I do take individuals at face value until proven otherwise. I would say
Mhm.
that the vast majority of people are genuine and reporting what they truly feel. But this is where the medical documentation prior to the accident can be quite useful. I'm reminded of a case I referenced earlier about the injury occurring in 2000, yet there was the documentation of chronic neck and back pain dating back to 2014. However, as a result of the accident, there was a clear demarcation where this individual then developed deteriorating function. They were no longer able to maintain their work as a personal support worker. There was a new diagnosis of some mental health issues that occurred after the fact. So, in that case, I think you can say that there has been a contribution from the accident, and I don't want to minimize that in individuals because oftentimes it is a significant event in their life, but you do have to consider the other contributing factors. And the fact that somebody is going through litigation or pursuing a claim in and of itself is a yellow flag for persistent symptoms. So the fact that they're in my office for an independent medical examination already is a yellow flag.
Interesting. And then just one technical sort of follow-up question, because we were talking about maximum medical improvement, and then we were also talking about a conclusive finding of chronic pain when something is going on and on persistently for, let's say, 3 to 6 months or more. What precedes the conclusive diagnosis of a chronic pain? Do you first assess maximum medical improvement and say that this person has reached that level, and then conclude that they are now suffering from chronic pain? Or do you first look at chronic pain and then say that this is the maximum that they're going to be at, and this is how they're going to be for the rest of their lives, and probably modify their lifestyle according to their pain?
I don't think the two are mutually exclusive. The definition of chronic pain is purely a time point definition. So pain persisting greater than 3 to 6 months. So what I will often say is that, but I'll also make the comment, and despite undergoing an appropriate trial of treatment, and therefore they are now at maximum medical improvement.
Okay. And because we're talking about some of these red flags and subjective ongoing complaints, I think both of us are curious to know what are some of the common pitfalls that you see in personal injury claims from a medical standpoint, from a medical perspective, that can undermine the reliability of a claim in your eyes.
Well, I mean, the obvious answer to that would be somebody who is describing symptoms that are not supported at all in the medical documents. Extremely rare, extremely rare. However, when you're talking about causation, you have to factor in the mechanism of injury. So, is it reasonable that that mechanism would have caused the complaints? I vividly recall an individual I saw several years ago. Let me take a step back. As part of the intake questionnaire that I mentioned earlier, the last page is a pain diagram. I'm sure you're all familiar with these. It's basically a blank picture of the front and back side of a body, and individuals are asked to, draw in or color in on that diagram the body parts that are affected by the injury. So I was reviewing this before walking in the room, and basically this individual had colored the entire body, head to toe, front to back, left and right side. So the entire body was indicated as being in pain. And the mechanism was he was traveling in a Walmart parking lot past a parking stall, and as someone was backing out of the parking stall, backed into the passenger side of his car. He was the driver. And as a result of that, he documented whole body widespread pain for the last several years. Now, I think most people would agree that that mechanism would be nearly impossible to cause that degree of bodily injury.
Right.
You also factor in what is the temporal association with the symptoms. So is there documentation that there was no medical records of neck or back pain before the accident, and then soon afterwards and ongoing there was documentation of that? Is that consistent with what you're hearing? And I think that's also important. People can have pre-existing pain and be in an accident and be worse off, and that's also reasonable as well. So those are probably the two key things that I take into consideration the most: the mechanism and the temporal course.
I would also just kind of add to that. I think that we can get a more precise analysis. We can also introduce a biomechanical assessment to see, like, well, given the force involved in an accident, you can use a biomechanical assessment to explain, well, what would have happened to the body, and then that can make it potentially, I guess I'm not an expert on this, potentially make your assessments a little bit more precise and just specifically with respect to your comments about the plausibility of the mechanism of injury. I do note we are at 12:55 here. We're almost out of time. So if anyone has some burning questions, now's the time, or forever hold your peace. And while we wait for some of these questions, I wonder if you could comment on if you have any experiential differences between when you're working with plaintiffs versus when you're working with defense. So, I mean, my first question is, a plaintiff walks into your office. Have have you noticed any patterns in terms of behavioral differences? Are they more antagonistic to you when they know you're working for the defense, for example? Anything like that?
I haven't, and that's kind of nice to see. It usually speaks to the genuine nature of most people. I was asked from a defense case to also review some surveillance video at one point in time, and the video wasn't very revealing, but obviously there was some concern about malingering or the genuine nature of the symptoms. But for luckily, I think for the most part, I do see most people presenting in a genuine fashion. I will say that the questions I get asked from the defense and plaintiff are oftentimes somewhat different. In particular, the plaintiff counsel usually wants to know more about an impairment rating, whereas I don't get asked that often from defense. And often with the defense files, I might be asked to review IME reports from other specialists and comment on specific components of their report and how that might differ with my opinion.
Mhm.
Mhm.
Do we want to shift over to some of these closing remarks, given the time?
Sure. Do we have any questions though? Do you
No,
want to check?
it looks like
Okay.
that the chat is quiet for now.
Okay, sounds good. So, just as some closing remarks and just some of the concluding questions, we just wanted to know what can insurance companies, professionals, and counsel do to support a thorough and defensible IME process? What can we do to ensure that we have the highest quality, objective report from you? Some of the steps that you think may be relevant.
Sure. So I think maybe the first thing to start with is making sure that you're selecting the appropriate specialist to assess the individual. Um, Sometimes I'm asked to see individuals who have clear orthopedic injuries that have required surgery, and I'm asked to comment on that. Now, although I'm comfortable seeing that in my clinic, I think if you do want an expert opinion, that should be directed towards the appropriate surgical specialist for an IME, not so much me who doesn't follow patients post-operatively and know the standard complications to watch for. Secondly, be very specific and clear in your questions that you would like answered, and if needed, provide definitions for terms that may have different meanings in different jurisdictions or could be confusing to the examiner. And then finally, if you can provide a clear, organized medical brief, ideally with duplicates removed and indexed in whatever order is easiest, whether that's chronological or by clinic. That would help tremendously, and it will save cost.
Okay, and probably also avoid selective documentation because sometimes we've noticed that some of these relevant documents are just not even provided to the expert. So they don't have a holistic and a comprehensive picture of what really is happening. And so I'm just taking the liberty to add that to that list.
Yeah,
Okay,
it
so
would be impossible for me to know what's missing if I don't know
Yeah,
what's missing. Yeah,
exactly.
yeah.
We appreciate that, of course.
we're running up to the very end of our time. So, in terms of, I understand that there was some issues with the deadlines for C credits to renew licenses today. So I can appreciate that. Our marketing group did send out an email. If you were to respond to that, that would be the best way to go about it. If you don't have an email with us, in terms of if you need any information or you want to let us know that you were in attendance here today, please send me an email at bzak@brownleelaw.com. Maybe can you guys see the questions? bzak@brownleelaw.com. And then you can send me an email. I'll forward you over to marketing. We do have, do we have time for one minute question? Darren says, I've noted in multiple negotiations that PCs mention that damage to a vehicle plays no impact in the effect of injuries to an injured party. Do you agree with this, or do you typically see a direct connection between impact severity and injuries?
It's a good question.
Yeah, good question. I don't think impact severity necessarily correlates with the financial cost of damages. I mean, I don't know about you guys, but my daughter was just backed into and has an older vehicle, and there was like $7,000 worth of damage for something that was barely visible. So I wouldn't put too much stock in the actual price of the damages quoted, but in the severity of the mechanism of injury. So higher speed accidents are more likely to result in more severe injuries than lower speed, for example.
Yeah, okay, so with that, thank you so much, Dr. Hlushak. I wish I had you for another 2 hours.
Yeah.
I think that your specialty is in high demand in the personal injury field, and I'm sorry that we've only have you scheduled for an hour. I understand that you have a hard out at 1:10, so I do want to let you go. With that said, if any viewers who have issues with their CE credits, I want to give you a couple of more minutes here to just pop in any questions that you might have into the chat. But with that, we'll be done our presentation. So if marketing, if you could please keep the presentation live for a second. And but Dr. Hlushak, thank you for attending. I really appreciate that.
Thank you so much for your time. This is a very valuable, very informative, and a very insightful session.
Yeah, my pleasure. And if there are additional topics that you'd like to have discussed in the future, I would be willing to do another webinar if there's interest.
Absolutely.
Amazing. Thank you so
Okay,
much.
thank you. Have a great day. I'm done.